All right, so we want to bring up our next testifier, new author on House File 99, Representative Freiberg.
Thank you, Madam Chair.
Representative Freiberg would would you like to move your bill?
Sure, I'd like to move that House File 99 be recommended to pass and re-referred to the Ways and Means Committee.
Okay. We have the bill before us. Representative Freiberg, please present your bill.
Thank you, Madam Chair and members. This proposed legislation was heard last session and funded in the 2018 vetoed budget bill. It would provide up to $1 million in grant funding to community paramedic programs who work on reducing opioid deaths. An ambulance service that received a grant under this proposal shall develop and implement a program in which community paramedics connect with patients discharged from a hospital or emergency department following an opioid overdose. With me to testify is Peter Carlson from the Mayo Clinic Medical Transport. Peter is the community paramedic coordinator for Mayo.
Mr. Carlson, please state your name and proceed.
Thank you, Madam Chair. My name is Peter Carlson. As mentioned, I work with Mayo Clinic Medical Transport as a community paramedic coordinator, and here's the community paramedic to support House File 99. And I think that the work community paramedics have done in our communities over the last 6 years is a testimony, and again, to kind of differentiate or delineate between community EMT and community paramedic. I'm referring to community paramedic. We've done very strong work as far as reduction in total cost of care through means of improving outcomes as a result of decreasing kind of acute care utilization. So really our work is focused on improving and increasing primary care access, which we feel like we're able to transfer that skill set into the population that's also dealing with addiction very well, and to assure that we're able to get into the community post naloxone or Narcan administration in all of our emergent calls, to then follow up upon hospital discharge or ER discharge, emergency room, to do an in-home assessment and a set of other tests you can see outlined in the bill as an opportunity to link our populations to a more robust primary care relationship and to assure that care plans are both created and adhered to. So open for questions, and thank you for letting me be here.
All right, thank you. Representative Albright.
Thank you, Madam Chair. This goes back to the House File
147.
147, and I'll just refer for the interest of the author. On line 1.18, we reference community paramedic team, and in the context of the conversation that I'm sure you heard with regard to House File 147, where's the assurance of staying in your lane, as you and I, Representative, have over the last several years recognized that most people that are suffering from an opioid type of addiction or substance addiction typically have co-occurring, symptoms or problems. So even more to the point of how do we assure that community paramedics stay in their lane and aren't practicing other professional disciplines? How do we assure the public that they're going to stay in their lane?
Representative Freiberg.
Yeah, thank you, Madam Chair. Representative Albright. I have not heard any concerns about that. I did ask. I don't have the expertise in paramedics that yourself or Representative Hewitt have. I have not heard from any groups that are concerned with that. I did ask the advocates for this bill if that would be an issue. They said it's part of what ambulance providers regularly do. He's here, can provide more information. As I said, I haven't heard any concerns. I don't see a rush on this if there are still concerns about that point, but none have been brought to me at this point.
Madam Chair.
Representative Albright.
Representative Freiberg, I don't see on here, but I'm just wondering, and you reference, constituent groups that probably, weighed in on this, but I'm wondering if, in the interest of, NAMI or other organizations that would have a very concerted issue with this, I'm just wondering if they had been consulted and if they have a concern or if they are neutral in favor of this bill, and I'm wondering, I have a couple of follow-ups, and I'm not trying to belabor it, I just am very concerned about the responsibility that we're laying on people who may not have the professional acumen that other disciplines have. So I hope you'll indulge me.
Representative Carson, anything? No.
Okay.
Okay,
I'd
Representative
love to speak
Freiberg.
up.
Sure. Yeah, actually, both, I've had a couple people who've requested to speak on this, if it could be turned over to them.
Please.
All right, thank you, Madam
Please
Chair.
state your
and
name.
Representative Alberg, still Pete. So I think, Peter Carlson, so to touch on the question, the concern, I am glad you're bringing it up, and I think the consistent request on this lane is intriguing. The community paramedic work that's been underway for 6 years and following kind of the rules and guidelines of the statute has been largely successful in a series of disease processes. So really what we're doing is replicating that process. And this is about compliance and primary care introduction, things that can be done very easily if we take the time to use the data in front of us to assure that there's some type of follow-up, which is not taking place today within the population. So it's not a question of ability or recognizing lane at all for us, but if you could be more specific with some examples, it'd be helpful for a more thorough response.
Thank you, Madam Chair. I'll use the example in past sessions where a welfare check by law enforcement has also included someone from the mental health profession discipline, because rather than, go in and not be aware of, situationally aware of what might be happening with the individual inside the room or inside the house, that there is a person that is trained for, in that case, possibly some de-escalation of the event. If someone walks in and they're not prepared for just the call, but yet they think there's something else going on. I'm just wondering, in the context of a community paramedic, if that type of a situation has been addressed, and how would you address it from a perspective of putting those community health paramedics at risk for what they might be walking into in a situation where they believe something to be happening, but a different situation might present itself to them very, very quickly with life on the line.
So
Okay, Mr. Carson.
So thank you, Madam Chair, and Representative Albright. Phenomenal question. I appreciate the context, and I think that's helpful to really be able to label a scenario and specific to that, but also broad to our discipline. There's a lot of education that's consistently provided as a part of our certification in order to have the level of situational awareness, and in our case, the verbal de-escalation, in addition to the motivational interviewing skill sets. When you bring up NAMI and other organizations, we are a referral professional. I think if I was given one floor in an elevator to explain to any of you what we do as community paramedics, it would be we create a network around the patient. And so there's no shortage of referral from us to any other body, be it home health nursing, NAMI, or any other entity that's needed in the care provision. The steering of that care plan is still being done by our APPs, or our advanced practice practitioners, and our physicians that are working in the primary care system. Specific to this bill, it's an opportunity where the data has not been able to show us a consistent relationship with primary care, and I think that's really the impetus for asking and supporting this bill, is that we want to help to create that bridge over to the system.
Madam Chair, if I could just ask one more question.
Representative Albright.
Thank you, Madam Chair. And I'm actually going to ask Mr. Spector to come down, only for just to provide a diversity of opinion on this, and to see whether or not his opinion or his position might be any different from what I've already heard.
Thank you, sir. Madam Chair.
Okay, please introduce yourself and respond. You would need to be at the table as a testifier. So why don't, we'll open it up to more testifiers in a minute, okay? All right, thank you. Please reintroduce yourself and
Thank you. Tony
respond.
Spector, Executive Director, EMS Regulatory Board. Representative, sir, could you restate the question for me, please?
So would your board have a favorable opinion of the expansion of this or not? Are there criticism or critiques that you would provide? I will add to my question in terms of some of these instances require translation into other languages. How do you address that?
Madam Chair, Representatives,
Yes,
thank you.
please.
This has not been a matter, I'm sorry.
Mr. Spector, go ahead,
Oh,
proceed.
thank you. This topic has not come before the board members, so this has not been brought before our board. So I believe it'd be premature for me to speak as to the board's position on a policy matter that hasn't been brought before it. What I can say is that you identified real-world situations, real-world concerns that hopefully a community paramedic program, if it was going to the field for post-discharge follow-up, follow-through, aftercare, as it relates to a naloxone overdose, it would be incumbent upon that program to ensure that the community paramedics are well-trained in that mental health. I mean, it covers it covers a panoply of matters. It would be incumbent, or for success, to be very well-trained and focused on that. But again, to be clear, this has not been a matter that's been brought before the MSRB board, so I'd be premature for me to speak of policy.
Representative Edison.
I think Mr. Albright's going to take all the time. All right. So in terms of looking at this, I think I have just a few questions for people at home or for people here. Can you just really explain the timeline of what something like this would look like from pickup, from where you first have contact with the person that's experiencing the overdose to the very end of what this looks like? And then I have a follow-up as well.
Representative, is it Carson or Spector?
Yeah, just Peter Carlson. Thank you, Madam Chair, and
Mr. Carson.
Representative. I kind of like it. It sounds nice. Makes my mother proud. So, great question. Probably should have walked through that. I apologize ahead of time. But we've got a substantial amount of data from programs throughout the state that are showing the ability to get in the home in as early as 3 days, which may sound like a stretch of time, but it's actually quite successful when compared to a lot of other interventions. So if one were to overdose and be in the need of naloxone, they could have a provider in their home in the form of community paramedic in as little as 24 hours and as long as what we're finding is an average of 3 days. So there are some constraints and variables that make it more difficult with the population that we're promoting and really excited to have the opportunity to work more closely with. And so we've got the infrastructure in place to be able to, through what are referred to as best practice alerts, alert our systems that we've created this interoperability or communication between so that we can deploy the resource. And so initially it's telephone outreach, but it's also introduction of the program. And so if you overdose, have the antagonist or naloxone to reverse your opiate overdose, you may be meeting your community paramedic while still in the hospital, in the emergency department, or on the floor if you required admission for your event. So hopefully that helps, but it's a tight window, and there's communication on the front and the back, because we see this representing almost a small fire, if you will, in terms of there's a lot of risk that there's going to be a recurrence of this episode. And so if we see it on the front end as paramedics, we're able to refer a rebound resource into that person's life. That can happen within just a couple of days and be instantly connected and communicating with that primary care team through the electronic health record.
Mm-hmm.
Representative Alderson.
Thank you, Madam Chair. Okay, so looking on the back, it says work with you're looking with a team of physical and mental health professionals. As somebody that has been a mental health therapist, I wonder how much training, just in terms of looking at like addiction and mental health, the paramedics are getting, and how are they working with those other professionals to make sure that the person who is coming out of addiction is well taken care of.
Mr. Carson.
And I would hand that, if okay with you, to Dr. Tangi. I think he can speak to the,
Beautiful.
yeah.
Introduce yourself and then proceed.
Yeah, thank you. My name is Pete Tangi. I'm board certified in emergency medicine and emergency medical services. I work with a community paramedic program in the metro area and have been involved with some rural community paramedic programs as well. To answer your question, Representative, the training would be tailored to the population that we would be serving and who we would be working with. And I think part of the key language in all of what we're talking about is the community paramedic team, which allows us to participate in whatever resources we've identified through our needs assessment. So for my community paramedics in my system, it might be working with our specific addiction counselors and our clinic and following an education plan and a prescription, a care plan that they help us craft and educate us to. Our basic knowledge of community paramedicine is in sort of the chronic disease management and like Mr. Carlson mentioned, the motivational interviewing and some basic tenets of just helping people improve their health. If it's another system that might be up, up in Two Harbors, Minnesota, that resources that are available there are going to be different, and that's going to be reflected in the education, training, and referral pattern of a program that might exist there. So I think really to highlight what we're looking for is, and what we've done historically is identified the needs of a community and a population, and then designed, and then taken that a step further to an individual and designed a care plan that works for them. And the community paramedics then have the initial education to do that, and then it's a continual learning process as well. That we go up, quite frankly, that we're learning with patients, with people. So it's understanding it, why are you using the drug this way? Why hasn't the previous treatment worked for you? We're going to help you get to the right place.
So I would like to bring to the members' attention that we have DHS here, and we wanted to, allow them to complete their presentation from last week. We have a few members who would like to speak. Becker, Fisher, Becker, Fisher, and Mann. And so if we can try to do this more quickly than not, that would be great. So, Becker.
Thank you, Madam Chair. My question is obviously, run through this process, you get called to a scene, overdose, and then obviously go to ER. And then what process does your community EMTs in your situation, doctor, what process do you do to identify those needs that will work with that person? Because like Representative Albright, my concern is are we going to be doing other things instead of what this grant is for? So how do I identify those needs and stay on task? And what would it, like you got called and I was OD'd on opioid and so forth. Some parameters you're thinking about in this program, because this is a very generic, this is very general, but we want to help the people, that are having those challenges. Can you give me a little oversight on that, please?
Who would like to take that?
Go ahead, Pete.
Yeah,
Reintroduce yourself.
Just I'm looking for the practical. I'm an EMT. I want to know the practical part.
that's great. So Peter Carlson and Madam Chair and Representative Schultz.
Close.
Baker.
Backer.
My apologies. I didn't do my homework.
Right?
All right. So another great question. I think to me it doesn't read as generic or broad as your interpretation, but the data for Mayo Medical Clinic transport that we looked at reveals a pretty large opportunity in the Narcan administration. We don't go 24 hours without administering it, and it's 55% of that is focused at 2 of our 12 sites in the state of Minnesota. So we see it as an opportunity to be quite specific in the application, the buildup of the resources needed as outlined in this grant to follow up in the home and actually be able to do the evaluation of prescription medications, do the medication reconciliation, refer to medication therapy management pharmacist as needed, do an HIV risk assessment, go through Narcan instructions, a basic needs assessment, all of this being done under the auspice of team-based care. And so we can bring it back to an integrated behavioral health atmosphere where I'm at and link the right, whether it's psychotherapy or other resources into the intervention. So I think that there's plenty of work to do in this space. And so that's definitely not a concern on our end. And it's very specific if Narcan is administered, and that brings us closer to our first responders, our police and fire as well, because we create channels of communication with the other entities that are administering Narcan in our communities. That will be the patient demographic or inclusion criteria that we use to perform this follow-up.
Thank you. No follow-up.
So this is what we're going to do. In the interest of time, we're going to lay this bill over until further notice. But if you guys have any questions that you would like to ask of the testifiers in the meantime, please do so. And so we're going to lay this over.